name is Ann, and me with Latony Robinson, Kimberly Shea Gilbert, and Jennifer Denton today will be presenting preeclampsia and HELLP syndrome. Preeclampsia is a hypertensive pregnancy disorder that affects approximately 5 to 8% of all pregnant women. This can develop gradually or suddenly and can occur anytime throughout the pregnancy, but mostly occurs within the first trimester or the last trimester actually of the pregnancy, and can continue on from delivery and up to 6 weeks postpartum. HELLP syndrome is also life-threatening and correlates with preeclampsia, which stands for hemolysis, elevated liver enzymes, low platelet levels. It affects approximately 15% of first-time pregnancies and increases to 16 to 52% after that. There is a 25% global mortality rate with this as well. When we're defining preeclampsia and HELLP syndrome, there's a few things we need to look for. First thing would be blood pressures are generally greater than 140/90. Patients have protein in their urine. They have increased edema, especially to their ankles, feet, face, can also be in their hands. Patients also experience increased headaches, nausea and vomiting that is abnormal outside the first trimester. They also can experience some epigastric and shoulder pain. They have sudden weight gain greater than 2 pounds within a week. They can also experience some vision changes, hypertension, hyperflexia, and also some shortness of breath with anxiety, which can contribute to a racing pulse, heightened sense of anxiety, the sense of impending doom, as well as pulmonary edema. Risk factors that we see with preeclampsia and HELLP syndrome, it often occurs in the first pregnancy. They have a pre-existing history, either themselves or family members of preeclampsia. Patient has multiple gestations, more than one baby. Also, we also often see it with chronic diseases such as high blood pressure, diabetes, kidney disease, transplant recipients, hyperthyroidism. Patients that are obese will often present with these symptoms as well. Women that are over 40 and under 18 years of age, patients who have polycystic ovarian syndrome, many in vitro fertilization patients, sickle cell disease, and as well as autoimmune diseases such as lupus, rheumatoid arthritis, sarcosis, and multiple sclerosis. So now we're going to look at our patient information. Patient EG, she's 28 years old. She's married. It's her first pregnancy. She hasn't had any other pregnancy. She's currently 37 weeks pregnant with a young baby boy. She's an elementary school teacher who contributes with moderate exercise. Her past medical history, she is a type 1 diabetic. She's had her tonsils removed, had appendix removed, her wisdom teeth removed, and she also currently has polycystic syndrome. Her social history shows that she doesn't drink, she doesn't do drugs, and her tests for STDs were all negative. She has, prior to becoming pregnant, her menstrual cycle was normal on a 28-day cycle. She also does take her prenatal vitamins regularly. Based on her family history, her mother had 3 children. As you can see there, it shows G3, T2, P1, A0, L3, meaning that she had 3 pregnancies, 2 that were to term, 1 premature, no abortions, and currently there are 3 living. And there were vaginal deliveries with her first one, or her third child, she had preeclampsia with.
So EG arrives to the emergency department alert and oriented. She has a severe headache and a sensitivity to light. She also is going through nausea and vomiting, which she states that she's had over the past week. She denies any vaginal leakage of blood or amniotic fluid, but she states she's having contractions every 6 to 7 minutes. And this has been for the past 2 hours. She states her urine output has decreased, and upon assessment, the nurse asked EG about her swollen eyes, and she states, that she thought it was from crying. She didn't realize that it was something that she should be worried about. She states she has also been experiencing increased swelling in her hands, legs, and also her feet. Currently, her pain level is 6 of 10, and it is mainly in her right upper quadrant of her abdominal area and remains constant through her contractions. She states she has felt her baby move in the past couple hours. Previous ultrasounds have shown that the fetus is normal size based on the gestational age, and the patient denies any previous or negative pregnancies. Her glucose readings have been abnormally high over the past several days. The patient provided a clean catch urine specimen and is now changed into a hospital gown. Electronic fetal monitoring is placed on her abdomen. Vital signs are taken and her urine is dipped for protein and glucose. Sterile vaginal exam reveals 2 to 3 centimeters dilated at 50% stage, or 2 station and 50%. Upon initial assessment, we find out that the nurse finds out that the EG is type 1 insulin-dependent diabetic. She has swollen eyes, hands, legs, and feet. She's also experiencing severe headaches with light sensitivity. She's been going through some nausea and vomiting, and she has the 6 out of 10 right upper quadrant abdominal pain. SVE reveals 2 to 3 centimeters, 50% at 2 station. Nursing interventions to be carried out include placing on an electronic fetal monitoring device, or an EFM, assess for frequency of contractions and fetal well-being, baseline vital signs, blood sugar, an initial weight, and assessing for urine for protein and glucose. As some of the vital signs and lab results start coming back, we have blood pressure readings of 180 over 99. Repeated 5 minutes later, it's 185 over 98. Heart rate is 98, respirations are 20, and her temperature is at 98.1. Blood sugar is slightly high at 150, and the height and weight indicates that she has a BMI of 26.6. Urine shows some trace protein as well as positive for glucose. Physician's orders include continuous electronic fetal monitoring, a fetal ultrasound, as well as non-stress tests or a biophysical profile. SVE in 1 hour, note any changes. Continue Q15-minute blood pressure readings. Some more laboratory tests, type and screen and cross-match just in case she might need blood in an emergency situation, and a urinalysis. Some questions about stage 1. What symptoms are EG experiencing that can indicate preeclampsia or HELLP syndrome? And 2, what preventative measures could could she have taken to assist in preventing these complications from happening? For question 1, there are many factors which can cause EG to develop preeclampsia or HELLP syndrome. She's a type 1 diabetic with decreased urine output, and she has a BMI of 26.6, which is considering her overweight. This is her first pregnancy and has increased swelling in her eyes, hands, legs, and feet. And additionally, she is experiencing right upper quadrant abdominal pain, severe headaches with nausea and vomiting. For question 2, controlling glucose levels, decreasing amount of salt intake, fried and junk foods, and increasing water intake could have prevented these symptoms. Exercising regularly to include stress-reducing activities such as yoga, meditation and deep breathing, and research also suggests that taking a low-dose aspirin and calcium supplements can also aid in the prevention of developing preeclampsia or HELLP syndrome. Ongoing assessment for EG, she is now admitted to the hospital and ongoing assessments are being performed. Lab results are being processed and fetal monitoring is being performed as well. Fetal well-being is observed as good. The patient states, my pain is becoming worse. The patient now is assessed at a 7 out of 10 pain level, and uterine contractions are now between 4 to 5 minutes. These assessments are reported to the doctor.
So, for stage 2, as you know, she's admitted to the hospital for monitoring. We're going to give her max sulfate, keep that on board, and that helps with the prevention of seizures because she has went into HELLP syndrome now. We're going to make sure she has a Foley catheter to monitor her INO for urine function. Also, you'll see that her blood pressure has gotten steadily higher. Her platelet count has gone down to 90. Her liver functions has increased significantly. Her liver function results have increased significantly. She is now passing more protein in her urine. We're also going to give her corticosteroids to help mature the lungs of the baby in the effort that we have to deliver early. And we're going to give her blood pressure medications such as hydralazine if necessary. We're going to keep reviewing her labs every 4 hours. We're going to repeat drawing those. We're going to have anesthesia on board for consult in case we have to do an emergency cesarean section. Later on, we noticed that she's starting to have nose bleeding. She has a new complaint with blurry vision. As we know, her output has gotten, her urine output has gotten more decreased. She's complaining of more shortness of breath. And then there's fluctuations in the fetal heart rate noted. So as for nursing interventions, we're going to make sure that she is alert and orient ×3. Make sure we administer her blood pressure medicines and other medications as ordered and monitor for side effects. We're going to prep her for the C-section and continue monitoring her for signs and symptoms of seizures. And most important, we have to keep her calm. Keep her calm, cool, and collected for this. And we also have to avoid providing direct capitation to the liver, so we won't cause any kind of rupture right now or any kind of pressure, which would make things significantly worse. So stage 2 questions include, what are some of the signs that indicate EG has progressed from preeclampsia to HELLP syndrome? And then what is the best treatment for HELLP syndrome? As you can see, there were significant changes in her lab results. Her vital signs got worse. Her blood pressure started creeping up even more. She had a significant decrease in urine output, and she had some vision changes. What I learned from this whole case study is that, cesarean section was the most common way now, back in the day, but now, due to her platelets, you have to, they'll try a trial of labor, and if the baby won't progress, they'll have to proceed to a cesarean section. Thank you.
So stage 3. So we just learned that the treatment for these two are the delivery of the baby. So patients now had the baby. That's an exciting time, but we still have to focus on the patient and getting her well in order to be able to go home and care for her child. So we're still continuously running labs and doing an assessment on her until she's out of the woods. So let's look at her labs. So right now we have her blood pressures going between 150, 20, and 90s. Her platelets are at 115, her AST 195, her ALT 180. You have your uric acid 7.5. There's no trace now of that urine and the protein in her urine, so that's getting better. Blood sugar is stabilizing at 125. Her fundus is firming. The lochia is moderate to small, which is normal, but they want to make sure that there's not excessive bleeding with that. So some of the nursing interventions that we need to look for in this patient is we want to maintain safety for her as far as blood pressure. We're going to keep the blood pressure medicines on board, whether it be like a PRN or a scheduled medication for her. We want to keep calcium gluconate, which is the antidote for bleeding, at the bedside. We're going to follow physician's orders and monitor for any change in the status of the patient. If she's starting to get dizzy, lightheaded, etc. Those are some things we need to look for. Encourage bonding with the mother and child. At this time, they may feel a little loopy. a little bit out of it. We want to encourage that time to spend. The baby may need to spend some time in the NICU just to make sure that their lungs have developed well enough to be able to be in the room with the mother. But if not, once the mother stabilizes, we need to try and do that transition. Encourage patient on possible long and short-term issues with the preeclampsia and HELLP syndrome, things for them to look forward later on. So since she's transitioned, the labor augmented with they did an artificial rupture membrane. So that's just basically they broke the patient's water for them, and delivers a baby boy. 5 hours following admission, she's unable to get an epidural due to her low platelets. They didn't want to cause any extra bleeding or any invasive, so they were unable, unfortunately, to give her an epidural. Her son weighed 4 pounds and 13 ounces. I guess they was kind of he was taken to the NICU just to kind of for precaution. Because he was diagnosed with the whole intrauterine growth restriction, EG is also monitored closely for worsening of the preeclampsia and HELLP syndrome and postpartum hemorrhage. She'll remain on the magnesium sulfate drip for 24 hours after delivery and probably put on a clear liquid diet. Her blood pressures will probably be every hour, depending on how she's doing with that. Assessment of lung sounds and reflexes every 2 hours. She'll have a Foley catheter because on that drip it does make them a little loopy. We don't want her getting up and down with that. Strict I's and O's and bed rest. The fundus will be checked. We said it'd be, we hope to be nice and starting to firm around the belly button, and then we'll notify the physician if there's any bleeding. So some of the postpartum questions, or stage 3, and the second one didn't get in there, but I'll go ahead and ask it. What are some postpartum discharge instructions that can be given to the new mother, and when should she call the physician? So let's find out.